Today we have discussed about malnutrition, the causes of malnutrition, the types of malnutrition, primary and secondary. Then we have talked about Marasmus and Kwashiorkor. Then we have talked about Anorexia nervosa and Bulimia. So very beginning, what is malnutrition? Definition of malnutrition is, it is just a poor nutrition or undernutrition. It is an imbalance between supply and demand of protein and energy for proper growth, development and function of the body. You can see over here, it is the imbalance. Don't forget, this is imbalance between supply and demand. Then the most important malnutrition, poor nutrition or undernutrition is protein energy malnutrition. Protein energy malnutrition, why it happens? If there is a decreased intake of protein or calories, or if there is decreased absorption or digestion of protein and calories, which will lead to weight loss, lethargy and general weakness. And there are some conditions which causes protein energy malnutrition, that are anorexia nervosa, bulimia nervosa, and obesity is very important. In obesity we have susceptibility of diabetes mellitus, cancer and atherosclerosis. What are the features a proper diet must have? First of all, a proper diet must contain normal amount of proteins, fats and carbohydrates, because we know protein is present in chicken, egg, dairy products, seafood and pulses, fish, cheese, butter and carbohydrate, wheat, cookies. So we know 1 gram of protein have 4 calories, 1 gram of carbohydrate also have 4 calories, and 1 gram of fat contain 9 calories. So a proper diet must contain balanced amount of protein, lipids and carbohydrates. Second thing is that a proper diet must contain amino acid and fatty acid, that are the building blocks of proteins and lipids. Lastly, a balanced diet must have vitamins and minerals, that are the trace minerals, zinc and all, magnesium and all that, because vitamins and these minerals are coenzymes and for the metabolic pathways. So now we will talk about primary malnutrition and secondary malnutrition. Primary malnutrition, if there is any deficiency of one or any of these things, like maybe deficiency of proteins or fats or carbohydrates or vitamins or trace minerals, deficiency in the diet, it is called primary malnutrition. Okay. And what is secondary malnutrition? If there is a GIT problem, a problem in the absorption or digestion, or there is increased loss of nutrient, or there is increased demand of nutrients, that is called secondary malnutrition. What are the conditions which causes the primary and secondary malnutrition are? First of all is poverty. Poverty, gurbat, maybe aged persons or the child of the poor family or homeless. In developing countries, poverty can happen when there is a crop failure or livestock death or in drought condition, khushk sali. Then there is another factor, a condition which may cause the primary or secondary malnutrition, that is infection. Infection having increased susceptibility of protein energy malnutrition. You can see it has a negative effect on nutrition, and that will cause the protein energy malnutrition, and they will increase the demand of these energy and protein, carb and fat. You can say these infections have a negative effect on nutrition that will start a vicious cycle. One side, a person is facing the infection, and on the other hand, the nutrition that have to fight against that infection, it is going downward because of negative effect of that infection to that nutrients. And third condition of primary or secondary malnutrition is acute or chronic illness. These illnesses, they will increase the basal metabolic rate. The energy demand of the body at rest condition. When your GIT is not working, when your enzymatic conditions are not there, when everything is stopped, but still at rest, your body demand of nutrients has been increased due to chronic or acute illness. And this chronic and acute illness, most importantly, the wasting disorders are very important. Wasting disorders are AIDS and cancer. Fourthly, the alcoholism. As we know, intake of alcohol will lead to the poor absorption of thiamine, pyridoxine, folate and vitamin A. And due to the abnormal digestion of these important substances, there will be abnormal utilization and abnormal storage of these nutrients, that will lead to the primary or secondary malnutrition. Then if we talk about fifth cause, that is ignorance of diet supplements, there are three factors or three members we have talked about. First of all, kids, children. Second are adolescent, and third one is pregnant female. They are ignorant. because they have an increased need of nutrients due to their respective age or condition, you can say. The first deficiency of in ignorance in diet supplementation are iron deficiency due to uses of artificial milk. Then thiamine deficiency due to the use of polished rice, and iodine deficiency due to use of food and water removed from ocean. Now we will come to the other sixth cause or condition which will lead to the malnutrition is self-induced feature. Why self-induced? The person is very obsessed with his body weight and image. Most common examples are Anorexia nervosa and Bulimia Nervosa, who are very much obsessed with their weight and image, and they having less or overeated food intake disorder. And now with seventh one, last but not the least, in others, malnutrition disorder conditions are if there is a GIT disorder, or if there is a genetic disorder, or if there is a malabsorptive disorder, in which we have in others category we have drugs also, because drugs have a mechanism of action to decrease the nutrient intake or to decrease the utilization of nutrients. So these Simon conditions are very important if we are talking about the conditions which are causing the malnutrition. Now we'll talk about few parameters by which we can assess or diagnose if the person is malnutrition or not, having a malnutrition or not. First of all is basal body mass index. Body mass index is calculated by weight in kg divided by height in meter square, and the normal value of body mass index is 18 to 25. If the body mass index is less than 18, it means the person is malnutrition. The other parameter to check the person is having PEM, protein energy malnutrition or not, we check the fat storage. How we check? We check the thickness of the skin fold. Third one is muscle mass. How we check the muscle mass? There will be decreased circumference of middle arm. And fourthly, we check the serum protein, in which we check the albumin and transferrin level. There will be hypoalbuminemia or hypoproteinemia. Then after the parameters we have talked about, okay, there are some signs of secondary protein energy malnutrition. First sign is there will be decreased subcutaneous fat, decreased subcutaneous fat in your arm, in your shoulder, on your chest and the metacarpal region. Second most common sign of secondary protein energy malnutrition is decreased muscle mass. The two important muscles are deltoid muscles and quadriceps muscles. Thirdly, there will be ankle or sacral edema. Ankle edema, there is no fun in telling at the ankle joint, and sacral edema at near the dimple of Venus. You just tell the patient to expose that area and just put a pressure on that sacral part of this patient, and you will see either the sacral edema is present or not. That is the third sign of secondary protein energy malnutrition. Now we will talk about some body compartments of proteins. There are two protein compartments in the body. First of all, there is somatic protein compartment, and then we have visceral protein compartment. In somatic protein compartment, we have proteins present in our skeletal muscles. Most common disorder in the protein in the skeletal muscle compartment, that is marasmus. Somatic protein compartment, in which the protein present in the skeletal muscles, and there is a problem abnormality in this compartment, it will lead to marasmus. What is marasmus? There will be loss of weight till or to that 60% of the person with respect to their age and sex, and there will be growth retardation and loss of muscle mass. And in marasmus, the subcutaneous fat will also mobilize and will be used as a fuel for the body, and there will decrease leptin production that will stimulate the hypothalamo-pituitary adrenal axis, that will cause the increased level of cortisol in the body. And cortisol, we know that the cortisol will increase the lipolysis in the body, so lipids will break down and will be used for the fuel of the body. Then lastly, there will be destruction or catabolism of somatic protein compartment, and the extremities becomes emaciated, weak, and there will be increased size or circumference of the head as compared to the body parts. As we know, if the extremities are emaciated, then it means the head looks like larger than the body comparatively. Then there will be anemia and decreased level of vitamins and decreased level of protein in marasmus. And then the second compartment of the body, that is visceral protein compartment. Protein stores in the visceral organs, most importantly the liver, and this is the most common protein energy malnutrition in African children. This is called Kwashiorkor. What happens in Kwashiorkor? There is increased level of protein deficiency as compared to other caloric deficiency, and there are protein losing enteropathies, for example nephrotic syndrome and extensive burn. Then there is a compare and contrast differentially diagnosed between Marasmus and Kwashiorkor is, in Kwashiorkor there will be normal subcutaneous fat and normal muscle mass. As we know, in Marasmus we have subcutaneous fat also go mobilize and helpful for the fuel of the body, lipolysis, and muscle mass destruction in the Marasmus. Then in Kwashiorkor we have scaly paint appearance of the skin because we have patchy zone of the skin that undergoes hyperpigmentation. That is called scaly paint appearance, darkly pigmented areas. And there will be fatty liver, apathy, listlessness, and then loss of appetite and decreased absorption in the small bowel lead to the decreased level of vitamins, decreased level of immunity, and there will be secondary infection. And not only these things, but also dependent edema or generalized edema will be there. Dependent edema, we know the edema of the foot or our legs, wherever according to the gravity. Then there will be loss or pale or dark color of the skin. So that are the features present in the Kwashiorkor. There is only one feature that is very much important and present in both conditions, that is hypertrophic bone marrow. In both conditions the bone marrow becomes hypertrophic, and there is a other clinical significance is that in bedridden patients or hospitalized patient there is increased risk of getting infection, and there is the wound healing process will go down, will decrease, and after surgery the rate of death will increase in bedridden and hospitalized patients. Now we will talk about our last point, that is Cachexia. What is Cachexia? It is the most common complication of AIDS and cancer. And what happens in Cachexia is generalized weakness, increased muscle loss or muscular atrophy, fatigue, lethargy, anemia, and edema. And what happens in this is the carcinoma of the liver, carcinoma of the stomach, GIT, pancreas, and lungs. And 30% of the death in that cancer patient is due to Cachexia only. And mortality is due to the atrophy of the diaphragm muscle and respiratory muscle. We know if there is atrophy of the diaphragm muscle and our respiratory muscle, then we can't respirate well normally. The person have to face the death. Then there are some factors which mediate Cachexia, that are the markers or mediators of tumor, and chronic inflammatory markers or mediators that stimulate Cachexia. Now lastly but not the least, we have talked about Anorexia nervosa and Bulimia nervosa. These are also malnutrition condition. What happens in the first of all, the Anorexia nervosa, this is a most common psychic disorder, and this is self-induced starvation is typical feature of Anorexia nervosa. Self-induced starvation. Then it is the most common psychic disorder. Then it is in both patients, not only in anorexia but bulimia also. The patient is very much obsessed with his or her body image and body weight. And now anorexia nervosa, the most diagnostic feature is amenorrhea. Before amenorrhea, we know in both anorexia and bulimia there will be abnormalities in the metabolism of the serotonin level in both anorexia and bulimia also. But most diagnostic feature in anorexia nervosa is amenorrhea, absence of menstrual cycle because of decreased level of hormones, and decreased level of estrogen will causes a feature called decreased bone density in that patients. And due to decreased level of estrogen, the patient mimics like a post-menopausal osteoporosis. Normally, the post-menopausal women will undergo osteoporosis due to decreased level of estrogen. But these patients, in spite of having 20 years or 28 or 25 years, not menopausal, but still they will mimic osteoporosis just like post-menopausal osteoporosis due to decreased level of estrogen in the body. And then dehydration obviously, and electrolyte imbalance. And one most important electrolyte, if that goes down drastically, that will cause cardiac arrhythmias and sudden death. That is called hypokalemia. Decreased level of potassium will lead to cardiac death and sudden death, cardiac arrhythmia and sudden death. Then lastly, if there is a decreased level of thyroid hormone in the anorexic patient, that will cause cold intolerance and skin scaly and dry, hair become loss of hairs, and constipation and bradycardia and all the symptoms of hypothyroidism. And then lastly, skin and hair, we have talked about that. So that was about anorexia nervosa. Now we will talk about bulimia nervosa. What is bulimia nervosa? The patient binges on food, attacks the food regardless of everything. He loves to eat everything, and after eating a lot excessively, they are followed by induced vomiting. So binges on food followed by induced vomiting. They eat a lot first of all, limitlessly, and then they will induce vomiting by themselves to reduce the weight and to maintain the weight and image of their body. Though not only they induce vomiting, they also use laxative and diuretics in order to lose everything from everywhere of their body, because they are obsessed with their body weight and image. Then but still it has better prognosis than anorexia nervosa, but because this is too much curable, because this is not the first most common psychic disorder, that is anorexia, that is most common psychic disorder, because psychological disorder takes time to be treated. Then it is most commonly present as compared to anorexia. More persons facing this problem, and the average age for bulimia nervosa is 20 years of age. They are more present in females, unfortunately 1 to 2% in females and only 0.1% in males. And basically they take increased amount of carbohydrates, not protein or lipid, just carbohydrate. They take more content, and there will be menstrual abnormality or irregularity in these patients, and less than 50% will face amenorrhea. But in anorexia nervosa, the diagnostic feature is amenorrhea only, but in bulimia nervosa, less than 50% will having, obviously the females will having amenorrhea conditions. Then complications, because they use, as I told you, not only they selfly induce the vomiting, but also use laxative and diuretics for their obsession. Due to that, there will be a electrolyte abnormality, specifically potassium, that will lead to cardiac arrhythmia, that will lead to pulmonary aspiration of the gastric content, and thirdly it will cause the gastric and esophageal perforation. As we know, as they induce vomiting by themselves, so the gastric content that is having acid HCl produced by the stomach, but innocent stomach is trying to digest that food that has been taken, but due to increased amount of secretion of HCl by the gastric glands or parietal cells, you can say, but due to self-induced vomiting, the acid will go towards esophagus, that will perforate the esophageal wall also. Then they will come upward, and it will cause the injury of the teeth, dental injury. It will not only burn the lips but also burn our tips of the fingers. So if you check a clinical, if you see a patient, just check their fingers, tip and lips and dental injury or not, you may diagnose the patient. And not only gastroesophageal perforation, but clinical features, you can see dental injury, lips, burn and fingertip damage. But it is possible that in an anorexic or a bulimic patient, symptoms may or may not be present, but then at that time you have to go for comprehensive psychological assessment of the patient. So that was about today's class. Is there anything I left in this video, because I am going to ask these questions in next class? Any question?
No, sir.
Anyone?
No, sir.
Seriously?
Yes, sir.
Okay. Thank you so much.